Good afternoon, everybody, and thank you for joining us again in one of these pieces of the FLASCO Disparities Committee and bringing up leaders in our oncology community, not only here in Florida, United States, but around the world. And it's an immense privilege and pleasure to have Dr. Lynn Schuchter here with us. That is our current ASCO president. We're just gonna have a very candid and very simple conversation about her views in terms of cancer care especially in our minority population, healthcare disparities specifically in cancer, but also as part of her presidential theme of also in things that we sometimes don't realize, and there's a lot of disparities in those areas, that is end of life care for our patients, palliative care as a whole. So Dr. Schuchter, welcome to our interview here with FLASCO, the Florida Society of Clinical Oncology. Again, my name is Jose Sandoval. I'm an associate member at Moffitt Cancer Center in the Department of Malignant Hematology, and it is a pleasure to have you here.
Thank you so much, and I'm actually thrilled. Are actually a model state affiliate and state organization. It's terrific, the work you're doing.
If you don't mind, since we are having a very candid conversation, will be okay, Dr. Schuchter, that I call you by your first name, Lynn, during the conversation?
Yes, absolutely.
Right. Thank you very much. So let's just start with basics. I wanted to see if you can give us a glimpse of who you are, and because I bet, and I can bet on this, that when you were studying as a medical student and even as a fellow, probably you wouldn't imagine that you will be in president of FASCO. That is a huge honor, right? It's the biggest, society of oncologists in the world right now. So tell us a little bit about you. How do you choose your path, and what led you to be the president of this society?
So yes, I'm a medical oncologist, and I've actually had my whole career at the University of Pennsylvania. And it's interesting to think back that it was during fellowship that a disease grabbed me, and that disease was melanoma. A little bit, I think, unusual, especially, let's just say 30 years ago, when for melanoma, we really had no effective treatments. But in part, it was my interest in immunotherapy and immunology and the different options that might evolve for patients with melanoma that led me to really study a disease for my entire career. And so I've been doing clinical research in the area of melanoma, and I've been chief of hematology oncology at the University of Pennsylvania, a role I just stepped out of last year. But the reason that I chose to run for ASCO president, and actually I ran and lost. I ran in the past and didn't win that election. But I actually have an agenda, and you touched on it with my presidential theme. And I spent a lot of time caring for patients with melanoma when we had no treatment. And really, I spent a lot of time in palliative care and having goals of care conversation and enrolling patients on hospice. And as chief, I really worked hard to try to help providers have these difficult conversations with patients. I think this is really hard work, having these difficult conversations. And we had a number of initiatives at the level of our institution to build capacity to have these difficult conversations. And so I wanted, actually, with the ASCO organization, to move this topic to continue the topic in a national and international way. And so my goal with my presidential theme is the art and science of cancer care, from comfort to cure. And that theme, I think, really encompasses the excitement of oncology and driving, new therapies, new cures for patients, but understanding that our therapies don't benefit every patient. So how can we do better? How do we help all of us have these difficult conversations with our patients? And so I hope that with this theme, with all that ASCO is doing to actually help drive that particular agenda. But I love ASCO. I'm deeply committed to the organization. Like many, I've grown up in ASCO in terms of different opportunities. So it's really ASCO's mission, its values, the impact that led me to pursue this leadership role. And I can tell you that I'm just so enjoying this work and look forward to the year.
Yeah, and thank you for doing this. I'm really, it is a challenge, right? Like, going across the aisle for different from our colleagues in the community. Us that, for example, in my case, that I'm in a hybrid practice between community academics and of course academics, but it's always challenging, right, to partake the problems on in oncology, not only on our country but also help in the global aspects. A lot of issues, right, from the academical issue, research issue, lack of funding, cancer medications right now that are, we have sometimes the shortage of cancer medications, burnout of our oncologists, and so forth and so on. But being the vice chair of disparities and health equity in cancer here from FLASCO, which, by the way, is one of the biggest societies, regional societies here in the United States, we are very interestingly in your focus in what do you think? How can we help to try to decrease that gap of disparities in cancer care? But especially now that you gave me that opportunity to ask about your presidential theme, especially in that area of end-of-life care, right? Palliative care, end-of-life care, especially for our minority patients. We've seen that, for example, there's evidence that in some instances there is not the same access, for example, to opioids or appropriate pain management for end-of-life care in minorities, and so forth and so on. So what are your thoughts on that? We'd love to hear you.
Well, and you've touched on so many important areas, as we're trying to deliver cancer care locally, in the community, nationally, internationally. And so I think that the specific area of disparities, access is a big issue, and getting patients to experts in their community, having access, removing barriers to screening programs and access to care is obviously so important. How we finance our healthcare system is a barrier as well right now for many patients. I think one of the important areas that ASCO was working on, and I think actually FLASCO is very engaged in this, is really ensuring that the oncology workforce is more representative of the populations that we care for, and that we're better equipped then to care for all types of patients. I want to mention a program that's actually happening right now because I was just with one of those students. ASCO has the Oncology Summer Internship Program. And the goal of this program is that people, different diverse backgrounds of students have elected to be medical students, and we all want to work together to have those medical students come to oncology. And so one of the programs, the Oncology Summer Medical Student elective, is that those medical students who may or may not know they want to go into oncology can enroll in this program. It's at more than 20 institutions across the United States. And those medical students are partnered with oncologists, all disciplines, radiation oncology, surgical oncology, and hopefully oncologists and medical specialties in oncology that those professionals come from underrepresented in healthcare. And this issue of pipeline, I think, is really, really important. So I had a medical student with me in clinic yesterday, and he's thinking about oncology, and you could see connections made with our patients, with understanding this field. So I think this is very important. And yesterday also had a medical student who's undergrad at Spelman, and it was terrific to have her in the clinic. She doesn't even know, what area of medicine she wants to go into. But I think this is one area, more access to clinical trials, and that ASCO's done quite a bit of work with the AAMC, so community oncology sites, to increase enrollment on clinical trials. But let me go back to your very specific question. This is a big issue, I think, about providers having timely conversations with all their patients about end-of-life care, and their data to show that Black patients or Hispanic patients, those conversations are not occurring in a timely way. This is really a challenge, and I think there are ways to train our oncology workforce to do better here. Access to palliative care specialists, enrollment on hospice, explaining, what those services are is really key. And I remember, you may know Cardinale Smith. She's a palliative care physician at Mount Sinai. She's actually on the nominating committee now of ASCO. And her father had advanced cancer, and he lived in a neighborhood where it was really challenging to get pain medication. They weren't available in the pharmacy. And she tells a really heartbreaking story of, she's a palliative care physician, and she couldn't get pain medications for her father, who was really sick with cancer. And so I think this awareness and making sure that people are having the appropriate conversations, getting family members involved is really important. And I'm glad you're asking about this, and it's a topic that I feel very, very committed to and passionate about.
Well, thank you very much. I totally agree, and I'm all in favor to include a curricula, right? Both in medical school and in residency, but especially in fellowship, dedicated rotations, right? Only on palliative care, but not only on the medical part, but the bed, side of bed conversations with the patients and family members, because it's a skill, right, that we all need to develop and learn. And I can tell you from the minority, perspective, I am originally from Colombia in South America, and I've been working with a Hispanic community here in South Florida now for quite a while. And I can tell you, for example, in the Hispanic communities, and a lot of times in our Black communities, even the word palliative care and hospice is it has different connotations. That's where probably we can, of course, help you from FLASCO. Anything that, any ideas that the leadership, like you're coming from yourself, of course, right, down through ASCO and us, ASCO, we can collaborate in different programs for access to end-of-life care and appropriate palliative care for our patients, including, of course, our minority patients.
And just to mention what you just said, I do think that, this work is really hard, but this is a skill that people can learn. You see that people have a natural ability to have these conversations, and the clinicians that you respect and model how they do this. But this is something that can be learned, and I think it is expected as oncologists that we know how to have these conversations. And for those providers who find this so challenging and can't do it, then they have to make sure that they say, meet with one of my colleagues, and make sure that a palliative care physician with expertise in having a serious illness conversation and goals of care conversation can have it. But I really believe that people can learn how to do this. And I think it's really important that we measure this. And then as we measure who has had the conversation. And that's where, we've done the work at Penn of looking at, sorry to say this, but report cards of our providers having the conversation. Are there disparities in which patients are having the conversation, which patients are enrolled on hospice, and looking at length of stay? I think it's really important to measure these things, real input of, was an ACP conversation documented? Was a goals of care and code status documented? Was the patient referred to hospice and their length of stay? And give this information back to the providers about how they've done and areas to improve.
That's amazing to know that information, right? Because we always said, and it's mea culpa, I'm a physician that treats mainly patients with you know, malignancy from the blood, right? You know, malignant hematology, they like to call this, but you know, we are one of the, I'm sorry to say that sometimes we're one of the worst. And
Yeah.
so sometimes there's some limitations regarding, you know, access to transfusions and things like that on the community. And we're trying to tackle that even, but it is even for us, right? It is important, like you said, at least to have the conversation, knowing that palliative care, right, is a whole spectrum and it's not just, you know, hospice care, right? And there's evidence, strong evidence that having a palliative care conversation and a team with them even improves outcomes for our patients. So Lynn, tell me, just changing subjects a little bit more and probably bringing things from your colleagues and past presidents from ASCO, what can you tell us about a specific you know, efforts that ASCO continues to do here locally in the United States and around the globe? Because I think a third of our colleagues from ASCO, you know, members from ASCO are around the globe, in terms of disparities in access to cancer care and in minorities and so forth, and health equity.
Well, yes, there are a number of efforts. I mean, one is establishing guidelines for low and middle income countries about, you know, priorities, understanding what are the priority medications for different governments to provide access to. You know, one of the interesting things that has come up in conversation in this work is that different communities around the world don't want to hear about substandard options for care. Yes, resources are limited, but you know, to promote a type of care that's not what is the standard of care and not what gets the best results doesn't really serve you know, countries well. And so it's still understanding, you know, what is really essential to deliver that high quality cancer care, and trying very hard not to, you know, don't want to reduce the standards because of resource limitation. Of course, some areas this is really challenging, and how do we finance these drugs? You know, one of the issues about the cost of drug is something that, you know, obviously ASCO has been working on, and working with bringing together groups like ADAM, the WHO, and looking at essential list of medicines. And how do we figure out ways to get access to these medications locally? How do we get governments in terms of how they're purchasing and prioritizing drugs? And getting very local, you know, at the city level, and these regional councils can be extremely helpful. So, you know, part of it is, how do you educate the workforce to have the expertise to deliver these medications that have a lot of cost? How do we figure out how to get these very expensive medicines to multiple locations? How do we think about, you know, effective screening programs where that may not be the priority? And across the world, getting back to our earlier conversations, having hospice care, palliative care, medications that are needed for supportive oncology, pain management are also really important. Also, ASCO is also very involved with establishing curriculum for oncologists, and really considering about, you know, curriculum then at the medical student level and fellowship about what minimum criteria are for oncologists in terms of their education. There's been a lot of interest in, you know, in some countries, there are very few oncologists and they're not the ones delivering the care. And, you know, this discussion of whether there should be any curriculum for primary care providers, enhancing the abilities of nurses to collaborate with the physician in delivering oncology care. So I would say a lot in the area of looking at how, you know, educational opportunities, how to think about access to these essential medications around the world.
That's a very good point, right? Because we always sometimes talk about the difference of outcomes between our patients, mainly driven by biology, different from different ethnic backgrounds and so forth. But more and more we have evidence that a lot of these actually can be abrogated or decreased just by access to care, right? And to improving these social determinants of health. And I'm glad that it still is one of the norths from ASCO. And thank you very much for that. Totally different topic. We steal from reminiscence from COVID, right? And from the shortage of the man force, woman force that we're facing in the oncology setting, both from oncologists down to oncology nurses, navigators, so forth and so on. Burnout is an active thing going on in our oncology community. So any efforts during your elected presidential period from ASCO to try to tackle or to decrease or ameliorate this burnout in the oncology community?
Well, I mean, it's so important, and it really follows Dr. Eric Weiner's theme. His theme, as you recall, was partnering with patients, the cornerstone of care. But a big part of what he focused on, and actually a recent ASCO retreat, is clinician well-being, getting back to the joy of practice, and how we have so many competing demands as we are trying to care for patients. But we remember what brought us to oncology and that interaction with a patient, that deep relationship that we form with patients, and the joy that we get from that interaction. So trying to, bring that in. I think that we still see that an important source of burnout is the electronic medical record. And I don't know how much you see that, but it's, people feel, oncologists feel, and the team, a lack of control, and you're just spending so much time in the record and being asked to do things that may not be what you need to do. And I think that there's much work that ASCO's doing in the sphere of policy that I think ultimately will really help us. When there's a change in how we have to document in the medical record, and making this easier and less words, and as we all become more accustomed to it, I think we'll be spending less time in the electronic health record. But it's still a huge source of dissatisfaction. When I speak to our oncologists, I think the other major issue is how much time we spend on prior authorization and the calls that we need to make to get the care that we know, guidelines supported, FDA approvals, and how much time, we or our team spend on prior auth. So from again, the ASCO advocacy and policy, and I know FLASCO as well, is looking at ways that we can engage with Congress on prior auth and ways to streamline this work. I think is really going to be essential. I mean, people are leaving patient-facing roles because of administrative burdens of providing care. I think providers want to be with the patient in the room, and just get really burned out by all the other hard things we have to do to just deliver the care that we know is the best for our patients.
Yeah, totally agree. I'm with you on the EMR. I think that it is a problem, right? It is a major issue. And we see this in the last couple of years. I don't know if you agree with me. A lot of really amazing clinicians and investigators leaving the academic, the practice setting, taking care of patients to industry and some other things. And we wonder why, but it's probably in front of us, right? And I'm glad also that prior president of FASCO and you, Lynn, are still focusing. Part of the effort of the organization is to help out our colleagues throughout the healthcare, the oncology healthcare system to tackle this. And I really like what you just said, and it makes it comes to your theme as well. The first word of it, right? The art and science of cancer care, right? I think we need to get back to that in a way. So talking about that, Lena, what do you usually do to to take away that pressure, to take away that burden in your free time, if there's any free time, right? I mean, I know you're incredibly busy.
No, I have two boys. They're 24-year-old twins, and I shouldn't say boys, but get to spend time with them some. But I love to be outside. I play tennis. I have actually a group of women physicians from work, and we've been playing tennis together for more than a decade. And we have a teacher on Saturdays. We don't make every Saturday, but we maintain that we are getting better every year. Maybe that it's not true, but we say we're getting better. So I love to be outside, play tennis, garden. I like to read and watch Netflix.
That's great to know. I love tennis. I try to play 2 or 3 times per week. I'm a little bit more intense, but love to have a match one day. You have time. I love tennis. I think it was one of the perfect sports for the pandemic. I love it. So well, I know that you're a very busy person. Thank you. We really appreciate your time with us here today at FLASCO. I would like to personally invite you to our summit we have every year. This is going to be our 4th time that we do our Healthcare Disparities and Equity in Cancer Summit here in the South Florida. We would love to have you. And if is there anything else that maybe I forgot to ask you, anything you want to tell us, that any exciting news that it's going to happen here in the next 6 to 12 months in ASCO, or anything else that maybe I forgot to ask you today, Lynn?
No, but I guess I would just add that the work that you're doing in FLASCO is really important. And what I've seen you do so effectively, first of all, you brought together community and academic institutions to try to solve problems locally. You've engaged at an early stage fellows. And I think this is really important. I think it's really important about the advocacy role that ASCO plays. And I have to say, it's only been in the last several years that I understand the impact of laws and legislation on how we try to deliver care. So the fact that you are engaging all levels in this work, that you have this committee structure, this is how change happens. I truly believe this. And so you're very active at a state level in terms of legislation, understanding the issues. You are getting the community involved. This is how it happens. And I feel very optimistic for the future that, still incredibly talented people are going to be joining us as we care for patients with cancer, and that the outcomes are going to just get better and better. But it starts with organizations like FLASCO and the work of your committee to engage in this way. So I just want to say congratulations to the work that you're doing and the vibrancy and urgency that you're doing your work. Thank you so much.
It was a real pleasure and an honor to interview you, Dr. Schuchter, and hope to see you soon here in South Florida. So thank you very much for your time. Ladies and gentlemen, it was another installment of FLASCO, and see you soon. Take care. Have a good day.
Thank you.